today. This is Dr. Muhammad Al-Shahri, Bariatric and Endocrine Surgery Consultant in Saudi German Hospital, Asir. I'm honored to chair this scientific webinar tonight, which was arranged and organized by Scientific Committee of Saudi German Hospital Group. I would like to welcome and thank all of you for your attendance on behalf of Saudi German Hospital Group. Our webinar today is about weight regain after sleeve gastrectomy. And this is a subject in which we should all be deeply interested because we are facing this problem every day. And weight regain after sleeve gastrectomy is a significant issue. Yet the defining and reporting and understanding this phenomenon remains largely neglected and debatable. So first of all, I would like to welcome our panelists tonight. Dr. Yusuf Ibrahim Al-Bub, he is a consultant general and laparoscopic surgeon, bariatric surgeon in Saudi German Hospital, Al-Madina branch. Welcome to Dr. Yusuf. Dr. Arindam Ghosh, he's a consultant gastrointestinal surgeon, Saudi German Hospital, Dubai branch. And Dr. Ahmed Muhammad Anwar, he's a general surgery specialist, General Saudi German Hospital in Cairo branch. So welcome our panelists for this tonight webinar. And for this subject and this complicated topics, it's a great pleasure for me to introduce our international speaker, Professor Norbert Rankel. Professor Norbert, he is the Chairman and Chief of Surgeon of Bariatric and Metabolic Surgery at Sana Klinicum in Germany. And his total experience is more than 25 years. He's the chair of the largest bariatric unit in Germany with more than 1,000 cases per year. Also, he's completed his fellowship from University of Texas in 1990. He is the founding member of German Bariatric Society. He is a professor of surgery in the University of Freiburg and Frankfurt, educating students, training residents and fellows. Also, he's supervising our fellow surgeons. He is a visiting professor and advisor for Saudi German Hospital Group. And ladies and gentlemen, please join me in welcoming Professor Norbert and for this talk today. And we'll leave the mic for him for presentations. And for our audience, any questions or comment, please write it and it will be answered at the end of this webinar. Professor Norbert, the mic is yours, please.
Well, thank you very much, Mohammed, for this very kind introduction. I'm honored by the prestigious panel. I am a visiting doctor and being proud of it, being a member of the International Surgical Group of the Saudi German Hospital Group that delivers fine and superb medical care to the patients all over the Arabian world. Now, do you see my slide and can you understand me well? Good. Weight regain after sleeve gastrectomy has long been known. Well, there's some technical problem. I'm sorry, it doesn't move. Yes, has long been known, and this is a slide from the very famous Swedish obesity subject trial, already published in the year 2013. This graph depicts the weight change over time in many thousand patients that were included in this prospective study. And the follow-up period is up to 20 years. And you see this typical curve of no change of weight in the controls, but a very good response early on after various operations, and an increase in weight, a partial regain of weight by the year 2 to 10, then stable weight. And this occurs after gastric banding, vertical banding gastroplasty, or Roux-en-Y gastric bypass. A very typical picture that we see in all studies with a long follow-up. These are more current data from the Indian Bariatric Registry, show the weight regain 5 years after surgery. And you see that 5 years after surgery, patients gain on average 7.6 kilograms after sleeve gastrectomy, 4.8 kilograms after Roux-en-Y gastrectomy, and 2.4 kilograms after one anastomosis gastric bypass. And what this slide shows very nicely is that the more restrictive a surgery is, the more prone it is to weight regain. This also occurs when patients are very well supervised. Here in randomized studies, the very famous STAMPEDE trial by Schauer and co. on diabetics. They were compared medical care versus sleeve gastrectomy versus bypass. And again, you see this good response in the first 2 years. And then there is some slight weight regain after both sleeve gastrectomy and gastric bypass. And with this weight regain, you see in the diabetics an increase in the glycated hemoglobin levels and a recurrence of diabetes in some patients. So this is also typical for this group of patients. Let me summarize the first slides. Weight regain is common. Actually, it is usual to some extent, and you may want to call it normal. Definitely, restrictive procedures are more unstable regarding weight increase, weight regain than malabsorptive operations. The weight regain may be associated with the recurrence of diabetes, but with the recurrence of diabetes can be totally unrelated to weight regain. Now, the question is, ladies and gentlemen, what is acceptable weight regain and what is, let's say, pathological? Now, looking in the literature, there's no universally approved definition of pathological weight regain. There are many definitions, and yet until now, the societies have not made up one uniquely accepted definition. Most probably will use the first definition, which is more than 25 increase of lost weight from the nadir weight. Others use 10 kilograms from the nadir weight. Others use more than 5 BMI points from the nadir weight. And there are other definitions also. Now, this is important for science because you should realize that the incidence of weight regain depends on the definition used. If you use a very strict one, like the first one with a 25% increase, then you find an increase frequency of 35%. But with other definitions, the frequency may vary. So for science, it's important to have one uniquely used definition. But being a doctor and sitting in front of the patient, I personally don't use those definitions. I prefer the definition that the patient wants to say to me, because if he's unhappy with the weight regain, if the weight regain is having comorbidities, then I would call it pathological, and I want to try to help the patient. Weight regain is just one element of the failure syndrome after sleeve gastrectomy. We have three factors that you may address when it comes to failure. The first is weight. You can have inadequate loss or regain. And in the literature, those definitions are not clearly separated. Many papers just deal with failure of weight and combine those two aspects. But actually, to look for a good therapy, one should try to divide those and find different aspects. Another one is the recurrence of comorbidities or the inadequate remission, and finally complications, and it's reflux that is the most dominant long-term complication we have to face with. Now, failure after sleeve gastrectomy is a matter of time. If you wait long enough, 5 and more years, the incidence of failure is very high. More than 50% of our patients have either inadequate loss or regain of weight, and recurrence or remission of comorbidities, and probably up to 50% will experience reflux on the long run. And many of those failures, many of those aspects come together. So actually failure is very, very frequent after sleeve gastrectomy. Now let's focus a bit on those. Very briefly speak about reflux. It was the topic of my last presentation, and probably most bariatric surgeons, and I guess also all the panelists too, would advise to have the Roux-en-Y gastric bypass as a good option in patients who suffer severely from reflux after sleeve, because the Roux-en-Y bypass carries a 50% complete and a 40% partial resolution rate for reflux. When it comes to weight, inadequate weight loss after sleeve gastrectomy, probably all of you would look for a technical error. Is it a good sleeve or not? Has it been done well? But if the sleeve is fine and the patient doesn't lose inadequate weight, actually we should admit that this was a wrong operation for the patient, and we should convert to a type of bypass. But we want to focus on regain. Again, the literature is not always really separating regain from inadequate loss. The literature is very poor in quality with a number of papers, but they all have small number of patients included and a very short follow-up. So the level of evidence we have is very low, and I will not be able to suggest an evidence-based pathway for treatment, but I would present you some data and my thoughts about this topic. The first question as a doctor in front of a patient is, do we have prognostic factors? Can we predict failure in our patients? I tell you, actually we cannot. If the patient in front of you, you will not be able to tell whether he's a good responder or not. There are some prognostic factors associated with weight regain, such as residual stomach, high rage, lower maximum weight loss, and eating disorders, but this really doesn't help you. It's a more scientific than a practical advice. So we cannot predict the bariatric results after sleeve gastrectomy. We have to face with it, and the patients come when they have regained weight. Long has the re-sleeve been the operation of choice. Re-sleeve, it's a fairly easy operation because you reshape the sleeve with a linear stapler, a fairly simple operation, so it's very nice to do it, but the results are disappointing. This has already been shown nearly 10 years ago by the Himpens group, and you see that the re-sleeve is poor on weight loss after re-sleeve, poor results, especially when you consider the excellent data you can achieve with the duodenal switch. If you look at the literature, you can still find a number of publications with surprisingly good data. So here's excessive weight loss up to 71% for re-sleeve after for weight regain. But if you look carefully, you see that the number of patients included is very small. And the follow-up is very small because the weight regain is after 24 months and not before. You may have excellent data within the first 2 years, but they deteriorate with the long term. And most data from the literature are very short-term data. Probably we all would agree somehow with this Italian synopsis. On the basis of our disappointing long-term result, it can be said that re-sleeve is not currently offered as a revisional procedure. Well, is re-sleeve out? I personally don't think so. There is a subgroup of patients, ladies and gentlemen, that can have a benefit from this operation. This is a current study, fairly new study from Azerbaijan. And they have examined those patients with a dilatation of the sleeve or a refundus. And this subgroup was examined. They had 34 patients, and none of them had reflux. So this is the curve for the average BMI. It started off with a 47. After sleeve, it came down to 37 very nicely. Within the next years, it slowly increased up to about 40. Then the re-sleeve was done, and then they had excellent results. Excellent results. Again, very short-term data, but really excellent results. And perhaps they have shown that in the subgroup of patients with a clear dilatation and anatomical problem, re-sleeve may still be a good option for our patients. So my personal interpretation of the data from the literature, that's what I would do also, is that overall I know the re-sleeve is poorly affected, but probably with the exception of sleeve dilatation as a secondary sleeve dilatation, or as caused by a poor primary operation. You should consider, though, that the complication rate of re-sleeve is higher than the primary operation. Alrighty. If the re-sleeve is not a very good procedure, probably the bypass is, and the Roux-en-Y gastric bypass has been the gold standard in revisional surgery for weight regain over the last years. But the data are again not very good. This is a study, I guess it is from Kuwait. Again, a very short period of only 12 months. They compared the patients with re-sleeve, 24, versus 12 in Roux-en-Y. They had fairly good results. Again, within 1 year, you have always good results with everything you do. But the point is I'm making here is that this bypass is no better than the sleeve in the first year. In the first year, the Roux-en-Y bypass is no better. Now, these are just some data from the literature, and probably they are not, this list is not complete, but it shows you something very nicely. Please look at the third row here, the follow-up. If you have a follow-up less than 18 months, the mean additional excessive weight loss of Roux-en-Y after sleeve is fairly good, about 30%. But if you have a longer observation period, 3 years, this 30% comes down to 20% or less. So again, these data very nicely show that you have a problem of weight regain for revisional bypass surgery after sleeve gastrectomy. After 2 to 3 years, the bypass doesn't seem to be good, the proximal bypass. But perhaps there is a subgroup of patients where the classical proximal Roux-en-Y gastric bypass may be beneficial in this patient group. This is a British examination, and they have divided their non-responders or their weight failures, inadequate weight loss or weight regainers, into a group with GERD and without GERD. It's a small group of 10 patients and 11 patients. But the difference in excessive weight loss is dramatic. It is 80% in those weight regainers who were refluxes versus 46% in the non-refluxes. Now, this is a British group, and I'm not aware of another paper confirming this, but there might be something interesting with this study that for the refluxes, the Roux-en-Y will have a good good influence on the weight curve after the operation. So let's summarize. Until now, the Roux-en-Y bypass is poorly effective, perhaps, ladies and gentlemen, with the exception of the subgroup of patients who have additional GERD or hiatal hernia. This is a brand new, very interesting study from Basel, published just a couple of weeks ago. They examined their patients of revisional Roux-en-Y after sleeve gastrectomy that 4 types of bypasses. It's the proximal bypass. Then they had the distal bypass with the same biliopancreatic limb length of 60 centimeters, but with a defined common channel of 1 meter only. Then they had a long biliopancreatic limb bypass, which is a bypass with biliopancreatic limb of 100 to 150 centimeters. But they did combine it with a short common channel of 1 meter. And fourthly, this is the classical one anastomosis gastric bypass, mini gastric bypass, with a biliopancreatic limb length of 150 to 200 centimeter, but a long common channel. Let's look at that data, please. So they had 12 patients with a proximal, 8 patients with a distal Roux-en-Y bypass, 20 with a long limb, and 12 with the one anastomosis gastric bypass. And this is the additional excessive weight loss at 3 years. It's about 20% when you have a short biliopancreatic limb length of 60 centimeters, either in the proximal or in the distal type bypass. But it's much better, namely 33%, when you have a long pancreatic limb bypass, either in this version or in the one anastomosis gastric bypass. And this very nicely demonstrates to me that it is the biliopancreatic limb length that is decisive upon the long-term results on the weight in the primary, actually, and this here in the revisional setting. Now, we are always worried about malnutrition, aren't we? And if you look at the hypoalbuminemia, which is a sign of severe malnutrition, the rate is 0 in the proximal, 1 of 8 in the distal bypass, 2 of 20 in the long biliopancreatic limb bypass, at 0 in the OAGB group. And this is also very important. We have to consider malnutrition. And you see that the groups with a common channel of 1 meter, they are prone to malnutrition. So keep the common channel longer than 1 meter, and you will reduce the malnutrition. And this is exactly what the OAGB does. But you can choose a long limb biliopancreatic Roux-en-Y gastric bypass with a longer common channel too. All right, let's add to our summary slide. Metabolic procedures are more effective as a revisional surgery for weight regain after sleeve gastrectomy. The conversion of a sleeve to a one anastomosis gastric bypass is a fairly easy operation, ladies and gentlemen. With the stapler, you divide the distal sleeve and you perform a gastrojejunostomy with the defined length of the biliopancreatic limb of 150 to 200 centimeter. The anastomosis is done according to the original Rutledge technique. And this graph here is from his original paper. And we also do this. We have this broad elephant foot-based anastomosis, or Rutledge calls it the cobra head stomach sleeve. It looks like that. It's broad to make sure that the anastomosis is well perfused. It is a posterior side-to-side gastrojejunostomy with a linear stapler, and the anterior defect is being sutured by hand and closed. So this is a straightforward, fairly easy operation. And it is very effective. Conversion into the OAGB, MGB is a good revisional surgery. This actually is also a new publication from an international Iranian group. And it is a meta-analysis of OAGB as a revisional operation after primary restrictive bariatric procedures. This includes sleeve, but also band and vertebral gastroplasty. But you see that the forest plots after 3 years here on top are all shifted to the left. Oh. And even after 5 years, they are all shifted to the left, indicating that RYGB is a very effective operation, revisional operation for weight regain after sleeve gastrectomy. These are our own data comparing our mini gastric bypass RYGB patients versus the Roux-en-Y gastric bypass as revisional operations. And here again, we confirm that regarding excessive weight loss and total weight loss, the RYGB is doing better in the early course after Roux-en-Y gastric bypass. And this would be indeed my preferred choice in this situation. Again, a very, very recent paper. I included mostly papers from the last 2 or 3 months. So there's a lot of science coming out regarding this topic, which is so interesting. This here is from Holland, from the Netherlands. And they have a huge number of patients, really huge number of patients. RYGB revisional ones, 145 versus Roux-en-Y gastric bypass, 267. And please, all those studies are retrospective. They're not comparable. They're not randomized. They're all retrospective. And by time, the number drops. That's the phenomenon we all know. The BMI pre-revision was comparable, 41 versus 40. The BMI at 12 months was comparable also, 31 to 32. But then thereafter, 1 to 2, 3 years, the weight remains stable in the RYGB group, but it starts to increase again after Roux-en-Y gastric bypass, and the difference is significant by 2 and 3 years. This phenomenon we have shown before. Roux-en-Y has a problem of weight regain in the revisional scenario, but the one anastomosis gastric bypass seem to have a more stable weight on the long run. Well, you probably have all heard of another operation that is being discussed in the meetings very heavily. It's the SADI, single anastomosis duodeno-ileostomy. And I will show you briefly the difference between SADI and RYGB. In the SADI operation, the dissection is done in the proximal duodenum, preserving the pylorus. And the anastomosis is done fully hand sutured, making it much more delicate and much more difficult and complex than the simple RYGB. The anastomosis is basically the same, but in the SADI, they choose a fixed common channel of 250 to 300 centimeters. Not the 100 centimeters we've discussed before, but 250 to 300 in order to avoid malnutrition deficiencies. Whereas we have this definite biliopancreatic limb length in the RYGB. This is basically the difference between those two operations. And actually from Doha, Qatar, just again, a couple of months ago, the first comparison has been published. This is the first paper. And they have a quite high number of cases, 49 in the group with the RYGB versus 42 SADIs. They started off with a very high BMI before the sleeve of over 50. The pre-revisional BMI was 43 versus 44, so this is comparable too. The drop at 18 months was 35 in both groups, so there was no difference. They were both effective with no difference between SADI and RYGB. They looked at the complication rate, and the complication rate was slightly higher in the RYGB, although it was not significant. Please, ladies and gentlemen, no significant difference. If you look in the complications, you see that RYGB had the problem with reflux. There were 6 patients with either persistence or de novo GERD, but there was no GERD problem in the SADI group. The SADI group had predominantly steatorrhea, but this was only a temporary effect. After 3-4 months, that went off. Regarding malnutrition and deficiencies, there was no difference between these groups. So this is the very first paper comparing RYGB and SAIDI in this revisional scenario for weight regain after sleeve. And I myself, I may have showed it with the last, within the last webinar. I'm very skeptical regarding GERT and RYGB. I must say, these are our own data. It's a Kaplan-Meier curve showing the effect of converting the sleeve to RYGB, including hiatal hernia repair in the patients who have intrathoracic gastric migration and GERT. And you see within 2 years, 80% of all the hiatal hernias and the reflux has recurred. So RYGB is no good solution, in my view, for patients who have reflux after sleeve. But I tell you the truth, the literature on this is controversial. This is my own personal experience. It has been published recently in obesity surgery. Okay, let's just come to closer to the end. Weight regain after sleeve gastrectomy. Sleeve, the re-sleeve may be a good course, maybe a good operation for those with definite sleeve dilatation, but the question is, should we ban the sleeve or not? There's no good data in the literature on that. The conversion into the Roux-en-Y gastric bypass is definitely good for GERT, and it may also be good for weight loss in the subgroup of patients with weight regain and GERT after sleeve. And probably we should repair the hiatal hernia, at least I do that. But then finally, it comes to the metabolic procedures, and this is the choice of today, the conversion of the sleeve into a metabolic operation. But you can have a metabolic Roux-en-Y, the long limb gastric bypass. You can have the one anastomosis gastric bypass, MGB or AGB. You can have the single anastomosis duodeno, ileostomy, SAIDI, I just talked about. And there's another operation, which is called the single anastomosis gastro-ileostomy. And this operation, ladies and gentlemen, is somewhat interesting indeed, because it combines elements from the RYGB or the SORI and the SAIDI. Let me just show it to you. The SAIDI, so the SAIDI, single anastomosis gastro-ileostomy, dissects the stomach as it does the RYGB. And this makes the anastomosis fairly easy because it is just a simple gastrojejunostomy with a stapler and hand suture of the anterior defect. This is the simplicity of the RYGB. But then it takes the idea from the SAIDI of defining the common channel length rather than the biliopancreatic bypass, rather than the biliopancreatic limb. So this is a combination, but there are no data on that in the literature. And I think this operation may have the future. We have done some, but my data are not ready to have real analysis yet. And you wouldn't believe it, but there is a consensus conference already published very recently in surgical endoscopy. This is a consensus conference, the first consensus conference on revisional bariatric surgery using the Delphi approach. And if you see at the panel, it is the who is who in bariatric surgery. Mahava, Himpens, Shikora, Ramos, Torres, Samas, Dillemans. You all know these names. They are big shots. So they sat together and they have their thoughts. And look at this, please. They did not consent on the re-sleeve. They did not consent on the Roux-en-Y gastric bypass, but they consented on the metabolic operations, BPD, RYGB, and SAIDI. Well, you may be surprised that I did not mention the BPDDS, but this is a complicated operation, and I think we have alternatives, more simple alternatives like the RYGB, the SAIDI. And probably hardly and only few surgeons will still do BPDs in this scenario, but we all agree that this is successful regarding weight and comorbidities. The other important message of this paper is what we've already seen, that the revisional surgeries always carry a lower efficiency rate and they always carry a higher complication rate. So you have to consider this when you talk to your patients. Let me summarize, and thank you for your kind patience. weight failure after sleeve gastrectomy, there is no evidence-based pathway for treatment. And I personally myself, I think I consider single factors that may influence the choice of my treatment, which is nowadays individualized. I think of the type of failure. Is it inadequate weight loss or weight regain? This may make a difference. What's about the nutrition? Is it the loss of restriction for the patient, or is he living on sugar, which really needs a metabolic operation rather than re-restriction? Then it's very important, look for GERD, look for hiatal hernia, intrathoracic sleeve migration, even if that is asymptomatic. I would not do one anastomosis gastric bypass, because I will have symptomatic reflux perhaps. If the patient is a super obese patient, he may really definitely need a metabolic rather than a re-restrictive operation. But then finally, it's the patient aim, preference. And I do know a lot of patients who will not want to have a bypass. They insist on having their sleeve. And in that case, you only have a chance at the re-sleeve. Comorbidities are important. And finally, the surgical expertise. And I think this is important. I have no surgical expertise yet. For the SADI, for example, I still do the one anastomosis gastric bypass. And before I change my practice, I want to see better evidence from the literature. Until then, I still do my OAGB. And when it comes to what is the best operation, I try to have components of revisional surgery. I look, does this patient need restriction? And probably I always combine this. When I convert into an OAGB, I may additionally do a pouch revision and make the sleeve smaller to have a restrictive component. So I combine these elements. And if the patient needs an anti-reflux operation, I do have to choose a metabolic Roux-en-Y operation. So this is my thoughts on this matter. And I'm very happy to discuss things with you. I'm very proud of being in such a prestigious panel. And I'm a proud member of the visiting doctor, the international faculty of the Saudi German hospitals. Thank you very much for your kind patience. Thank you.
Thank you very much, Professor Rankel, for this enlightening and entertaining, informative presentations on weight regain after sleeve gastrectomy. And we appreciate having this mysterious area clarified. So I will leave now the mic for our panelists, Dr. Youssef and Dr. Arindam and Dr. Ahmed, for any questions or comments. We'll start by Dr. Youssef. Okay, please, Dr. Youssef. Dr. Youssef, please, can you unmute your computer? Dr. Youssef, can you unmute your computer, please?
Yes, okay. Now, are you hearing me now?
Yes, we are.
Okay. First of all, I'd like actually to thank Professor Norbert for this very informative lecture. And I just would like also to make a comment on those options or revisional surgeries you mentioned. We are in Saudi Arabia here, so in Medina, we are doing a lot of cases here, around 700 to 1,000 cases per year. Mainly common cases, we are doing the sleeve gastrectomy. Very minimal numbers of cases, we do it as a Roux-en-Y gastric bypass, a proximal one and not distal one. We did some distal and some convergence from an OA, from a minimal gastric bypass to Roux-en-Y for a patient who actually had an stomal ulcer and severe GERD. What I'd like also just to say here that I did around so a very minimum number of re-sleeving, and sometimes I'm doing glycation, re-sleeving plus glycation of the stomach when there is no place to put your stapler. So, but the most common cases, so we did it, is by we found it before we do the re-sleeving, we do an gastrography in CT, an enhanced CT for the abdomen, just to see that if the fundus is really dilated or not. If the fundus is dilated, and sometimes you will find the antrum is dilated, then we will do refundectomy. So that's a proper one. And we do an glycation on the antrum, some glycation. I would say that we don't have really a long run or long-term follow-up. We did since 2 years, 13 cases. I can't really judge on this small number that is really a good operation or not. But what we have seen or confronted in our OBD, that the patient, when they regained weight post-sleeve gastrectomy, they are asking actually for re-sleeving or do glycation, or whether endoscopically or laparoscopically. And they try always to avoid or try to run away from our recommendation to do a Roux-en-Y gastric bypass. Reason, because they don't like actually to be committed to take the multivitamins supplement so post-surgery. So they want us to take the supplement for a definitive time. They don't want us to have the dumping syndrome. They like also to have from when we explain to them in a very nice way that the bypass is the good solution for them, or the mini gastric bypass, they usually may agree for the mini gastric bypass than to agree for the Roux-en-Y gastric bypass. Maybe the type of the surgery, they are afraid of that cutting, doing anastomosis and like this. Although that by mini gastric bypass and by Roux-en-Y gastric bypass, we are doing the same things. We are giving the patient supplements. Now, most of our patients in Saudi Arabia, in Medina, I mean, who regained weight post-sleeve gastrectomy, they are coming to us with GERD and dilation of the stomach. So the first things we think about it is actually to do bypass for them, but they refuse. Now, do you have any experience, Prof, that repairing of the incompetent hiatus hernia or small hiatus hernia, or have you any experience on this, that an anterior choroplasty and posterior choroplasty, which one is more effective than the others? And do you have an experience that if we do this, the patient will really, his GERD is going to be improved or not? So this is my comment actually also to that, and I'd like also to hear your answer actually about those two questions, if you don't mind.
Thank you very much, Dr. Yusuf. From the question, I realize you have a great experience and you have a large caseload per year. There are cultural differences indeed, and some patients do not want a bypass, even if we recommend it, and this also occurs in my practice, although the frequency is lower. Most patients are afraid of dumping That's rather than taking tablets, because it's easily financed, and the insurance companies often cover those vitamin supplements. Patients are not afraid of tablets rather than dumping. If the patient doesn't want the sleeve, I will not try to convince the patient, because then it's going to be bad. He will suffer. I mean, never try to convince the patient. If he wants his re-sleeve, this is fair too, because you don't lose anything. You can do the re-sleeve, and when he comes back years later with another weight regain, you can still do the bypass. So there's an option. We just should be honest to the patient, saying that there is a chance of regain weight even after the re-sleeve, and the literature shows that the long-term results are not that good. As you said, patients with GERD, they seem to do better. I've shown you the British study. Patients with weight increase and GERD, they seem to have a better weight loss after revisional surgery. Now, our own experience on many patients is extremely poor regarding the repair of the hiatal hernia and the re-sleeve, because the sleeve is not much larger than the esophagus, and the sleeve is like a mouse. It can go through any hole. Even if you do chloroplasty, the sleeve can migrate into the thorax. There's no study and no personal experience dividing between anterior and posterior chloroplasty. But what I do in the scenario, I personally do in the scenario of a patient who really doesn't want the bypass, but he has a reflux and a hernia. I will take down the stomach. I will do the posterior plasty, and then I do. I take the falciform ligament, the teres ligament, and I take the teres ligament down the abdominal wall, pull it behind the esophagus, and wrap it around. It's an old-fashioned operation. Some call it the Narbonne technique. It is being published in the obesity surgery. Some groups have revisited this old operation for bariatric surgery in order to stabilize the sleeve. It's acting like an anchor in the abdominal cavity, but still, the recurrence rate is even high after this. So once the sleeve is migrated in the thorax, fixing it into the abdomen is a real problem, and we all have not the solution yet. We have no idea whether a mesh can do things. I don't like meshes, foreign bodies over there. The biomeshes have failed in the non-bariatric population. So keeping the crura intact, preventing a re-hiatal hernia, that is one major problem we are facing in bariatric surgery, and I do not have a perfect solution. Perhaps the teres ligament is a good option.
Go ahead.
Thank you very much. What we are doing nowadays, what I'm doing, so in Medina, I'm anchoring the posterior wall of the sleeve when we do have a hernia at the left crura with a stitch. And I'm taking actually at the pancreatic fascia 2 to 3 stitches to let me say that to replace or to make our sleeve in a better shape to prevent actually a twisting of the sleeve. This is what we are doing now here. And I'm doing it since around 1 year. I'm not seeing that there is any really, I didn't face any problem until now. I don't know what is in the long run or long-term follow-up, what will be the problems. So what is your comment about this, if you don't mind?
I think we need a fixation of the sleeve. I totally agree with you, and we don't know which is the best option. I think this reminds your technique reminds me of the old hills where they fixed the stomach at the posterior crura. The data at that time were inferior to the fundoplication, but perhaps it's a very good option. And I would ask you to observe your patients well, publish the data, and this may be the best solution. We do need an anchor of the sleeve, and perhaps your way is a good way.
Thank you.
Okay, thank you so much, Dr. Youssef, for this comment and questions. We'll go for Dr. Arindam if you have any questions or comments to Prof. Norbert.
Oh, what a wonderful lecture. Thank you very much, Professor Norbert. This is really put in a nutshell. I would like to share a few thoughts of mine regarding this sleeve regain, weight regain, or inadequate weight loss. I'm not equating both, of course. So in literature, there's just a few technical stuff, as you said, that the fundus of the stomach are actually three types. One is a riding type, where the fundus rides on the crura, a flat, and a drooping. These are the three categories of fundus which had been traditionally discussed and described in old Hallensched's book of anatomy. So when we dissected, when we tried to do that, we found that whether there's any correlation or not, that whether the people leave more fundus in any one of these two. This is the first question. And second is, I agree with you that I think the CT volumetry is crucial, as Dr. Youssef has mentioned, before we embark into any solution, because our data in different, almost 5-6 papers, which I just saw, and it is amazing how the volume differs from 108 milliliter to start with, 250 ml to 550 ml, even to 1,105 ml. This is post-sleeve gastrectomy sleeve stretch. Either it is because of a retained antrum, retained fundus, or widened sleeve. Now, whether it is because of a sleeve stretch, because of a potential obstruction in the high pressure of the sleeve, at the pylorus there is an obstruction of the high pressure of the sleeve, or something else, we don't know. Because each time, if we look back to those sleeves and the videos of these sleeves, many of them were almost perfect sleeve. Not to talk about, of course, saving the retained antrum sleeves. So and now I'm sure most of the people who do sleeve, they remove almost 30-40% of the antrum. So do you do the same, or you do still the classical way of keeping almost a whole of the antrum there? Well, you do the same. So another thing which is important is that weight regain is not always a surgeon's fault. So there are some things which are crucial for it. That is metabolic, as you said. There are leptin, there is serotonin, and there are papers which have shown that increased serotonin in the body, and inadequacy of lowering down the ghrelin, and also increased leptin post-sleeve, because stomach being an endocrine organ, whatever, does not help a sleeve to remain as a sleeve. Another one thought is very, very important thing which we came across in the paper is diminished REE, that is a resting energy expenditure. As our weight drops, the metabolism changes, the adaptation occurs. As we know that, but there is a quantification of REE, whereby there is a tremendous amount of change which happens within REE, which also prevents inadequate weight loss. Another thing, which is hypoglycemia. Patients who develop hypoglycemia will be gaining more weight. So these, apart from that, there is another thing which you have touched, which is very, very important for all of us, our patients, apart from this, is that TFEQ R18 questionnaire, whereby they come across with eating behaviors. Either it's a CR, that's a cognitive recognition, that the person who understands a green veg is good, he takes okay, and he possibly doesn't, is not going to get that much of sleeve and weight regain. Then apart from that, there is UE, there is uncontrolled eating. Anybody who is an uncontrolled eating, or as we call it, grazers. Now, we have to identify these people, as you said, preoperatively, who are what? Are they grazers, and it can be found out by this TFEQ R18 100 scores, 0 to 100 scores, which we as a surgeons do not do so if you have a multidisciplinary staff, preoperative counseling of a dietitians and finding out there is any psychopathological problem also along with these eating disorders, which needs to be looked into. As far as the re-sleeve, I'm so happy that you said that the re-sleeve need not to be just put aside. We do re-sleeve, but though in the re-sleeves there are 16% of leak rate. So that is one thing which almost puts someone down in the literature. That's a pretty much high, but it is neofundus resection. I think that is the most important thing which we have to do. And as you mentioned nicely, and we have I want to know about adjuvant medication, which I think also needs to be looked into. Whether we give weight loss meds post-operative sleeve. I know as surgeons, we know that those things really do not matter a lot. They do not work a lot probably, but the literature has got some hints that they may at least stop reducing at least 5% of the weight loss. So one of the important thing is the topiramate. That's what we don't get it in India. We don't get it here also. So endoscopic suturing and gastroplasty, I would like to know your thought about it, which is coming in a big way in the sleeve regain, weight regain. And I want you especially to talk about it. In the Indian study, where we also was a part of it, the Baig was mentioning about that, I think there is some amount of underestimation of the weight regain. I must say that. We had discussed this in long discussions. And I would also ask you sincerely about those refluxers with sleeve regain, weight regain, where long BP limb RYGB, long PP limb RYGB, not anastomosing at the distal end, but anastomosing 100 centimeter from the GJ with a long limb. Your thought, your wisdom, please, on that.
Well, there are many thoughts, Dr. Arindam. Thank you very much. With most ideas, I can totally agree with. Especially, we have to counsel the patients before. Before you do a reoperation, revision surgery, we would all agree that these patients have to be extremely well examined by the multidisciplinary team. Regarding the placation, well, for me, placation is another way of restriction. And sometimes it's better to do a placation than to do a resection, especially coming closer to the fundus. You have the very thick stomach, the very thick wall. You want to use the stapler. You're afraid that the stapler will leak. Why not do a placation, which is very nice, very fine. It has the same effect if you do it openly, probably as doing a resection, but it has no leak rate. So placation is a good alternative. It is, in my view, a restrictive operation if the stomach is not so much dilated. This is my thought on placation. Now regarding dilatation of the sleeve has been demonstrated, as you said, in the literature by serial CT scans. But my personal view is that many of the so-called re-sleeves are probably inadequate operations, especially the combination of GERD and the refundus. I think probably the retained fundus was a surgical miscalculation. And a retained fundus and a small hernia will always give way to regain weight and also GERD. And that's probably the reason why this subgroup of patients, which do in principle are good responders to the sleeve, but the technique was wrongly applied, they do profit, they do benefit from a fundectomy and a fundoplication and a chloroplasty. And the British data suggest that. So this is my thought on that. Now, indeed, hypoglycemia can occur. It is not that common after sleeve gastrectomy, but hypoglycemia is a well-known cause of weight regain in bypass surgery, but I've hardly seen hypoglycemia after sleeve gastrectomy, I do have to admit. Then your thoughts on additional medication. I think the next years will show that we are combining surgery and medication. We have good efficient medication with the GLP-1 agonist, for example. They do have a metabolic effect. And the idea of combining this in primary and especially in revision surgery is very attractive, but we do not have yet data. So please do this and check your data and present your experience so we can use it. And the final point was the long bypass. Now, there are two randomized studies from the Netherlands, one showing in primary operations, one showing that the long biliopancreatic limb is the major determinant for weight regain. We've shown this before, we all know this now. This is one effect of the RYGB, a long biliopancreatic limb of 150, 200 centimeters, for example, not longer. But the second study from the Netherlands was also very interesting, and I liked it. They compared the short pouch and the long pouch, let's say a 10 centimeter pouch, because please remember that in the one anastomosis gastric bypass, the gastric pouch is 15 centimeters. It's super long. And in the normal gastric bypass, it's probably 5 centimeters. But if you choose a 10 centimeter gastric bypass, you will find that the longer pouch, the longer gastric pouch, which is small, has a more restrictive component than the short pouch. And it probably has a smaller, in my view, a smaller dumping syndrome rate. So nowadays, I personally, if I do a Roux-en-Y, I choose the long pouch, long biliopancreatic limb version of it, but not have a short common channel. I hate the short common channel. I'm afraid of malnutrition. This is my personal view. So I think the long biliopancreatic limb Roux-en-Y version has a great future.
I must add in this that for my all primary operations and my go-to almost is most of the time now is RYGB or mini gastric bypass, whereby it is the sleeve, the pouch part of it is not economic. It is non-obstructive, as Rathlete said. So it is not 36 or 40, it may be 42, 46.
Yeah, exactly.
So that is one thing which I must tell you just for that. So post sleeve also the thing which for me is, apart from all the evaluations, I would try to definitely go ahead with an RYGB unless contraindicated.
Dr. Arindam, yes, for my German patients, the RYGB is my primary choice, or my primary choice as a primary surgical operation, and I select the patients. I select the patients for the sleeve rather than for the RYGB. I would agree with you on that topic.
Thanks.
Okay, thank you so much, Dr. Arindam, for this nice comments and questions. Dr. Youssef, any questions or comments?
Just a little comment about the minimal gastric bypass. Many of the people, if there is a contraindication, we know it. So this is smoker patients, the one who is having GERD. Those patients are not suitable actually for mini gastric bypass. The people, those are suitable maybe for a Roux-en-Y gastric bypass, whether proximal or a distal one. But I fully agree with the professor and that the common channel should really, I'm really always afraid of having a 1 meter common channel. I'm always avoiding to have this, making it at least a 150 common channel. We should really have, just to avoid the malnutrition. And we know that our patient, I think that they are really not a good, they don't come for follow-up usually. So the last solution we make it for patients to follow up the patients. We gave them the option to communicate with us through the social media, through the WhatsApp, explaining their problems. And I usually cut 1 hour in the morning from my time to respond or to answer their questions. Maybe this will increase the follow-up and the satisfaction of the patients because they don't come to the OBD, not now only. So this even so before corona viruses, before COVID-19, they don't come because they are, first of all, they don't want us to pay for the OBD. Maybe so because the hospital is a little bit far away from their residency, and there are manufacturers and really preventing them so to come to the OBD. So that's why we offer to them the social media so they can really communicate with us. We'd like also just to answer their question and not to come to us then later on with a severe complication and then we really difficult to deal with it then. Thank you.
Okay, thank you so much. I'd like to ask Dr. Ahmed, is he still with us or he's left or he has some technical issues? I think Dr. Ahmed, he left. So we have about more than like 500 participants and a lot of questions, and we are running out of time. So just we'll go with a few questions, and this is going to be distributed between the panelists and our professor. So there is a questions here. Is there any relation between gastrectomy and pregnancy and fertility? And so, Professor?
I didn't get the question. Would you repeat it, please?
There is a question. Is there any relation between sleeve gastrectomy, pregnancy, and infertility?
Pregnancy and infertility.
There's a relationship, a positive correlation, actually, in my view, that the fertility increases with weight loss, and actually sleeve gastrectomy is a perfect indication if a obese lady is seeking fertility and wants to have a baby. It's a wonderful operation. There are no data suggesting that the interruption of pregnancy or small for birth rate or the disability rate is increased. So sleeve gastrectomy has a very positive impact on pregnancy. And if the patient is pregnant, you are probably much safer with a sleeve than rather with malabsorptive operation because you are afraid of having malnutrition. So sleeve is very positive on fertility.
Okay.
This
okay.
one, can I comment?
Yes, please.
So like this is weight regain of sleeve again happens in more frequently after pregnancy.
Oh yes, during pregnancy, yes.
Just like pre-op BMI is also an important factor for the regain. Similarly, pregnancy is also that much.
Yes, correct.
Dr. Yusuf, there's a questions regarding good evening all. I want to ask one question. One of my relative had undergone this surgery 5 years ago. Still, he's having vomiting and cannot eat anything, even to drink. What may be the reason?
I would say that the habit of eating and drinking most probably is wrong. Now, we should really, we always explain to the patients, when you eat, you should really eat a small amount of meal and you eat it with a small spoon. You should really chew it properly. And when you eat it, leave and you feel that you are swallowing the meal, keep the meal when it is reaching so the stomach, and he usually or she is feeling this, you should really keep it at least so for 15 to 20 seconds, and then you take the other continuous to eat then after this. I would say that vomiting and and nausea, do you usually, whether to the habit, whether so that the patient is eating and drinking at the same time? And this is wrong. And we usually tell them, so you should really 30 minutes before and after, you should start to drink or stop drinking. And usually they are, whether they are taking really a big amount of meal so that they are not satisfying themselves with the small amount of meal, but they are eating up to that point that they really feel the nausea and vomiting. And some of them, they are drinking, they are drinking juices with conservative materials. We noticed that some patients who are really drinking this early, the juices with conservative material, and this is going to irritate the mucosa of the stomach and causing really this nausea. This is what we noticed. So usually when our patients are coming to us and telling us, and this is a common question actually, that they do have vomiting and or nausea, we tell them, so these small meals we are describing to you to be given to you, you should eat it at least for 20 to 30 minutes and not in 5 minutes. 5 minutes or 2 minutes, this is, if you eat like this in 5 or 2 minutes, this meal, then you will have this type of symptoms. Now, when those symptoms are going to appear, I think it is at the maybe 2 to 3, 4 months commonly, but not after this. Now, by this patient, if she is having this problem, then we have to think about many things, whether that this stomach is not fixed at the posterior wall of the abdomen. So we need actually to do a gastrography in swallow to see if she is having some twisting sometimes or something like this. Then, or she is having an stenosis. Then she is having this chronic vomiting or chronic nausea. So this is my answer for this question.
Okay, any comment, Prof. or Arindam?
Yes, persistent vomiting and rapid weight loss is very suggestive of an anatomical problem. It's the stenosis at the incisura angularis, or it's a twist, as Dr. Yusuf said. And if the patient is counseled and still has this problem, we should look for these anatomical problems and then convert him to Roux-en-Y bypass, I think.
The CT reconstruction, 3D reconstruction would many a time tell us that there is a twist or stenosis at a specific area. This is one. And second, sometimes in non-mechanical vomiting, which sometimes happen and more commonly happens rather after RYGB, can also happen in patients of sleeve. And in that situation, mirtazapine or that sort of an antipsychotic drugs might help.
And just to add, a migrated pouch in a gastric bypass, a migrated pouch can have this kind of vomiting when it's going to be fixed and trapped in the hiatal hernia. So it can occur in bypass patients too for anatomical reasons.
Okay, so the next questions, Dr. Arindam. Did you observe increases in oxalate renal stone post-sleeve?
Post-sleeve?
Yeah.
I
oxalate renal stones.
No.
No. Prof?
I didn't get the answer, the question properly, I must say.
And increases in renal stones post-sleeve.
Oh, no, not in the sleeve, no, not in sleeve, no.
Not in sleeve.
No.
Dr. Yusuf, the same answer?
We really faced 2 cases. But those 2 cases, we face it, they are prone to have a renal stone. So before they had this. and most probably because they are not drinking enough fluids, so that's dehydrated, and they may really have this renal stone. But 5 to 10% gallstones, yes. Renal stone is only 2 cases or 3 cases through our experience. Yeah.
So it can happen in a distal bypass.
Oh, yes, definitely.
Yes.
So one question is, what about gastric balloon post-sleeve?
No, there's just one answer, no.
Okay. So there's the questions. I think this questions was answered before. What is about adding some medications to sleep? One questions from one of the audience. I did gastric band 12 years ago, and now my weight increased rapidly, and also I did total thyroidectomy for more than 15 years. She's on thyroxine, all diet controlled, but why this happened? I mean, why this increase in weight rapidly after gastric band?
Well, if I may answer is, first of all, she has to check whether her thyroid levels are adequate. Secondly, the band has only a limited lifespan, and this is actually also a very typical history. After years, then it's the end. I tell the patient it's the end of the band. But before I do say so, I would do a thorough investigation of the position of the band, whether it's still functioning, whether it has migrated, whether it is loose, and then choose the therapy accordingly.
Okay. So last questions before we just end this webinar. What are the criteria before doing a surgery as a primary or redo surgery?
The indication for a primary sleeve is morbid obesity. And if you have your own selection criteria, especially in a patient who is a volume eater rather than a grazer, sleeve is a good option, as we heard. And especially those patients who are non-compliant, a restrictive operation is safer than a malabsorptive operation. We heard that before. A sleeve as a revisional operation is the re-sleeve. And I think we have nicely discussed this with the panelists. It may have a good chance for patients who want to keep their sleeve, who have a sleeve dilatation, a retained fundus, whatever. It may have good results, even though regaining weight after a re-sleeve, that may occur, but the patients will have a nice life for the next years to come. And perhaps they change their lifestyle and have better results than expected. So re-sleeve is not out, although it is not being consented by the current Delphi process. But I think in our daily practice, we have to offer patients who are carefully selected for a re-sleeve.
Okay, so I'd like to thank you, Prof, very much for this webinar and for this informative information, as well as Dr. Youssef, Dr. Arindam, and hopefully we can get this webinar again soon, similar topics or any different related obesity topics. I'd like to thank the organizing committee and scientific committee of Saudi General Hospitals for allowing us to have this program, and hopefully we'll see you soon, inshallah. Thank you very much.
Thank you, Dr. Mohamed. Thank you, Dr. Yusuf. Thank you, Dr. Arindam. It was a pleasure and an honor to being with you.
Thank you.
It's such a prestigious panel. Thank you so much.
Thank you very much.